We know Helen is trying to go vegan. We also know about last Tuesday. We know Helen is trying to go vegan. We also know about last Tuesday.
Das gibt mir jetzt ein. Ich tue mal hier die Portion. Jetzt nehmen wir schon 11 da. Das gibt mir jetzt ein. Ich tue mal hier die Portion. Jetzt nehmen wir schon 11 da. So, hello. Hi, I should be live now. Good evening, everybody, depending on your time zone, obviously. Just first, let me check whether you can hear me. Can you hear me? Maybe just somebody write something in chat so I can know that you can actually hear me. Okay, that's fine, and image is there too. All right. So, yeah. Hi guys, welcome to my second live stream. Basically, I did this once before just to test everything out, and this is now the first in the new year, and I will try something new here today. Not sure whether this will actually work. I hope there are no technical glitches. And yeah, so what I aim to do in the next half hour, maybe 60 minutes, is go through a few cases. We focus on hip MRI, and we compare surgical notes. So after these hip MRIs, the surgeon went in and we tried to do or work it backwards. So basically reading the surgical note and then go back into the MR to see whether we can actually see what the surgeon saw during arthroscopy. So I think it's a fun exercise, and I like to do this because I think it really helps with learning as well, going back and maybe identifying stuff that we were not really aware of before the exam, or before the surgery rather. So starting right off with the first case here, it's a young patient, 27 or so, and let me just open up the surgical note, if that works. We see this here. So obviously the original surgical note or report was in German, so I used DeepL. In case you're not familiar with it, DeepL is a very good artificially intelligent based translation tool, and this is what came out. So he had surgery beforehand, and we have the first MR here before the surgery. Then he was not really getting better, as we can see here. Steroids were not really helpful, and so on the ArthroMR, there was some increased controllable damage. This will be on the one that we are actually looking at, but they saw that the offset was corrected well, and they saw some scarring there. And now what they wanted to do, they wanted to go in and do adhesiolysis, because we know that in hips after surgery you can have adhesions from the capsule to different structures, and these adhesions can be symptomatic or painful for the patient and reduce its range of motion, although we don't see any obvious residual cam deformity or pincer component. And I think just to give a quick repetition here, I can just open up here this article. It's available in the internet, so I don't assume there is a copyright issue, and you can just Google the title and then you will find it yourself. So we quickly just go through here a few cases. So what adhesions look like. So normally you can see it. You resect some bone, and the joint capsule can then, in the post-operative healing phase, attach there, and there can be some adhesions. They can come in the middle, but they can also start laterally and then going medially. And then something we basically always see is the obliteration of the perilabal sulcus, as you can see here. So normal, this is the preoperative, and then it's completely obliterated. So these are kind of the findings that we try to see when assessing this kind of adhesions. So going back now maybe to the surgical note first. So what did the surgeon actually did? So they gave some antibiotics, then they went in. And so let me just see it. You can obviously read it. So they went in, and the portal, so okay. So they identified the pars reflecta of the rectus femoris tendon. And this is basically a translation error. So what the German report says is that basically the pars reflexa is attached to a large scar convolute. So we can try to see that. I think that's basically the first thing that we want to do. Now, let me just switch a little bit here with the screen. So, and we make this go away. So we try now to identify this scar convolute, this large scar convolute, so obviously a impressive finding along the pars reflexa of the rectus femoris tendon. So let me just pull up here maybe the preoperative scan first. Let's zoom in. Let me just quickly check the chat. Oh yeah, so yeah, obviously you will be able to watch the whole video afterwards on YouTube if you don't want to stay up, depending on where you live. And yeah, that's basically that. So this is now the preoperative scan, and we can see already here we still have, this is an arthrogram, fluid running up here into the perilabal sulcus. So this is very normal. This sulcus can have different dimensions. It's most prominent in the most superior portions, but basically it goes all around. And after surgery, most often in nearly 100% of cases, this will be obliterated. So we will try to see whether we can see this on the post-operative scan. So this is still the preoperative scan. So the rectus femoris tendon, it's not well visualized here. This is the most anterior section. Let me just pull up a second plane here quickly, this one here, so we can better see it. So this is the inferior iliac spine, and the rectus femoris is this one here. And if you remember the anatomy, so rectus femoris tendon has two heads, or two components up here. So we have the pars recta, the direct head, and then there is the pars reflexa, or the indirect head, which you can nicely see here. So this black line here, this one here, is the indirect head of the rectus femoris. And also here you can nicely see how one portion of the tendon goes all the way back here. And if you compare this on the coronals, it's actually this structure here. So this is the pars reflexa of the rectus femoris tendon. You can have avulsions, tears, etc. there. And we will now try in the post-operative MRI to see where there is a large scar tissue. So basically, let's see. This is now the post-operative MR. And I will put the pre-operative MR next to it so we have a better comparison, for example, like this. So pre-operative, post-operative. Now let me just zoom in a little bit. So remember this perilabal sulcus. We have arthrogram and gadolinium in here, so we can nicely see how this is open. Now in the post-operative setting, we can still see it here, interestingly enough. In the more maybe posterior aspect, it's completely gone, not well visualized, and we can see the pars reflexa here. So now let's move anteriorly, and we can start to see it's getting quite ugly here. So look at this. Let me just synchronize it so we have maybe less issue. So now they are synchronized. So moving anteriorly, and we can start to see there is a lot of hypointense, muscle is intense tissue. It seems to be more than it was previously. And you can also see they did some pincer reduction as well. They resected some bone here, and where they did the pincer reduction, we can see a lot of hypointense signal. So this is basically a scar convolute, as the translation translated it here, and we can still see portions of the rectus tendon. That's which one? This one maybe. So let's try whether we can see it here. So this is the rectus femoris tendon coming up. Then we have the direct head, which is completely normal, and we should now have the pars reflexa or indirect head going down here. And here we can see this large scarred area here, and you can also see they put a anchor in. So they did basically a pincer reduction. They removed some bone. Let me just open up the pre-operative MR again. I should probably have some labels. Anyway, so this is the pre-operative, and you can see there is some either a os accetabile, but it can also be an old rim fracture from the kind of impingement that the patient had in sense of a stress fracture. So this one here is a bony fragment or os accetabile that might increase the coverage in the upper segment here, and this basically leads to a pincer component in this kind of patient. So they went in and resected this one here because we notice, if we go now to the post-operative MRI here, that this bony fragment, if you will, it's not there anymore. So they resected it. The labrum was obviously also a little bit detached, so they used one anchor here to put it back in. And now exactly where they did this kind of surgery, we have now this scar tissue there. Now going back to the full post-operative MR again, you can try to see. I think this illustrates this nicely, where we have this complete scar tissue here. It looks very irregular. Tendon is not well visualized as well. And we can also see this kind of fibrous bands here, if you look here. So these are all tiny adhesions, threads of tissue that are interconnecting stuff that shouldn't be there. And you can somehow imagine that if you have a lot of scar tissue there, that this might limit your function as well, similar to the bony fragment or bone, os acetabular bone that was there previously. So let's go back to the, let's see, where is it? The translation. Yes, there it is. So that's this large scar convolute along the pars reflexa of the rectus tendon. So basically they went further. They just seeing there, the capsule was completely closed. This is something we sometimes see in the post-operative setting, where you have a defect in the joint capsule here. For example, sometimes there is just a large gap. You can have contrast that you inject going out, maybe just bulging a little bit out. So they have to open this kind of joint capsule in order to get into the joint, and sometimes it's ripping apart post-operatively, and you have these defects in the joint capsule. But this one is okay. And then some splits, old sutures. They saw some old sutures, they removed it, not so important. So in the lateral compartment, so we are not talking about this area here, we find ventrally partly sail-shaped, partly flat scarring, which is released. So there should be now some scarring between the joint capsule and the femur, and they released this. So let's see whether we can identify this. So I think the best sequence might actually be the radial one or the transverse oblique. So here in the most upper portion, there was still some defect in the joint capsule, as you can see here. I think this is what they meant with ventrocranially. There is a split again of the iliofemoral ligament. Okay, there were some old sutures, they removed it. Okay, that's fine. And then, where is it? Peripheral visible. No, there. That's it. So maybe just mark this in yellow. Okay. Oh, you can't see it. Okay. So let's put this away. I'm sorry. Translations go away. Okay. So again, starting up here. So here, there is still in this ventrocranial portion a gap of the joint capsule, whereas more caudally or distally it's still intact. So now they went on and said that there are some small adhesions that they released. So we try now to identify these adhesions on this oblique image here. Yeah, Mike, I just realized it. So there is some delay between when you write something in the chat and when I'm actually talking here. I think it's a few seconds. Yeah, anyways. So if you look closely, you can see there are some very small adhesions there. So this one, for example. And sail-shaped, it's quite a descriptive term, so I think we cannot really apprehend this from the MR images alone, but it's not a complete adhesion because we still have contrast here. So it's just coming down here. You can also see some very, very subtle adhesion, a tiny thread here. Whether these are clinically relevant, it's questionable, probably not, because you see adhesions in the postoperative setting quite a lot. And maybe that's a good time to show you this study quickly here. Let's see, where is it? It's not coming up. Oh, that's why. If you go, where is it? No, it was this study. So just reading the abstract, I think that's enough. So they looked for the frequency of this kind of adhesions. And if you look here, so capsular adhesions at the anterior femoral neck were present in 1/3 of the patients in both groups, and groups were symptomatic and asymptomatic. So you will be seeing small adhesions here in this area quite frequently. All right. So that's that. Now going back to the report, see what they did. Open this one up. So the offset is corrected, so there is no residual cam deformity, there is no bony growth or new bone formation that's impeding the offset, that's fine. And the cartilage layer shows superficial erosions laterally at the femoral head. Alright, so the cartilage layer shows superficial erosions lateral at the femoral head. So that would be most likely lateral of the femoral head, must be this very most lateral portion of the femoral head. I think this is probably not easy to see just based on resolution. Maybe there is a little hick here, but I noticed this over the last couple of reports that I read, that they sometimes see kind of quite long erosions at this most outer portion, and I really struggle to see this on MRI. We can maybe try to see it here on. So this would be the most lateral portion. So there is some irregularity there in the cartilage. So probably what they saw there. And you can also nicely see again pars reflexa and this very large scar tissue here with this kind of adhesions there. Okay. Moving on. No progression of damage compared to the first arthroscopy. That's good. Okay, over a distance of 3 centimeters, complete scar of the recess. Okay, I think we saw that already. Functionally insufficient of the labrum. Okay. So they released the labrum again. I think that's not very important. And the extension, just going through the report here quickly. Okay. Yeah, I think they closed the joint capsule then and removed everything. So that's basically all they did. They went in, they released the rectus femoris tendon here, so they released these adhesions. They released some adhesions on the more anterior aspect, and that's basically it. So I think I don't really know how the patient now is doing, unfortunately, because I think this was just recently. But we will see in the future how this goes. So keep a lookout for these tiny adhesions here, and especially I think we see another case later on, these more pronounced adhesions, especially along the pars reflex of the rectus femoris tendon and this perilabal sulcus. I think this is something that we should maybe have a look at. All right, now let's just quickly have a look at the chat. Yes, minimize the report. I'm really sorry. This is kind of stupid because I don't have this. I know what I do. I do it like this. All right. Go away. There you are. So going back, just quickly showing you. So I was just saying, keep a lookout for these very tiny adhesions, and especially adhesions at this area here where we have the rectus femoris tendon, the pars reflexa. Okay. So very good. So we will now move on to the next one, I guess. So we got this one here. You can see the image. That's fine. And now let's see what's going on here. Just quickly loading up some images here and just quickly showing you the translation as well. And this time I have to overlay on my screen as well, so I will not forget to put it away. Still trying how to do this properly. Okay, case 2, where is case 2? So, case 2. So, patient after surgery, initially good course, then again symptoms. So, painful mobility. So they even did a 3D motion analysis post-operatively, which showed normal mobility, indicating that the restricted motion was most likely due to extensive scarring, which was confirmed by Arthro MRI. That's the study that we will now have a look at. So they went in and did the surgery. Okay, they just do the normal stuff. They go in, let's see, lateral access. Okay. So even when they go in, they can already feel this kind of scarring of the joint capsule. So if you do arthrograms, especially after arthroplasty, you can sometimes feel this with the needle if you do aspirations, etc. as well. It's a very particular feeling for those of you who do these kind of interventions. And then they go in, they visualize the joint capsule, and there is extremely coarse scarring found, especially on the medial side, so medial being on the central portion of the joint. And here again is a large convolute between the pars reflecta of the rectus tendon and the joint capsule. This is completely removed and the rectus tendon is dissected free. Okay, so we have a similar situation in this patient. This is the post-operative MR. I don't have the pre-operative scan, unfortunately. So let me just quickly go through here. I like if they do a pelvis just to get an overview of the whole situation, where you have the contralateral side as well, pubic symphysis and sacroiliac joints, because you don't want to miss something else that might actually be symptomatic for the patient. We can already see some susceptibility artifacts here on the left hip. That's the one that was operated on. Now, going here, you can see it was a arthrogram. And if we scroll through, we can see again these kind of susceptibility artifacts. And in the first surgery, they resected some bone here to do this kind of offset correction or resect the cam deformity. And then we can already see here some very tiny threads. They should not be relevant, right? So you can't imagine that something like this, it might not even be continuous, right? So, but I would still report this. The joint capsule on the lateral portion, it's not adherent here to the shaft. It's not medialized in a sense, so I think that's quite okay. And we don't see kind of a bridge, kind of this sail-shaped adhesions that we had in the first case. So, not too bad. But, as opposed to the previous case, we now have a large defect in the joint capsule here. Let me see whether they actually reported this on the report. No, they don't specifically talk about it. Oh yeah, they do. So maybe I can quickly show you this. I think it's important. So you can see, where is it? Yeah, the capsule feels rough on palpation and a clear gap is felt ventrocranially. which is covered by a fine membrane. So it's not like an open defect, which we kind of can understand, because if it's an open defect, we would expect the contrast to go out. So there must be some coverage here in this cranial portion that is still containing this kind of gap here in the joint capsule. It's quite extensive gap here. Certainly also worth reporting. So let's quickly also check the Perilabal Sulcus. Here it's still okay. In the more posterior portions it's obliterated. And then here it's completely obliterated. So this is now again in the area where we have the pars reflexa of the rectus femoris tendon. Also, it does not go far enough anteriorly, but we can appreciate there should be a pars reflexa, and there is a lot of scarring going on. We have susceptibility artifacts here, a very large susceptibility artifact here as well. And this was in the initial report rated as anchor dislocations. And I've seen this a few times. It's not the first time that I saw reports that mention these kind of susceptibility artifacts as anchor dislocations. I can't show you the radiograph, but the anchors this patient has, as you can see here, when they did the labrum refixation, there are several ones here. They are not like metal anchors or metal anchors. And if you see this kind of a artifact, you should definitely check your radiograph. And the radiograph was completely normal, no metal. And this is just abrasive change from the surgery. It must be some microscopic metal fragment that's causing this artifact. It's not a dislocated anchor. So I think this is a good message. Be mindful calling this a dislocated anchor if the anchors are not metallic in the first place. It looks strange, and I had calls with patients that didn't believe me, etc. So, but it's not a dislocated anchor, right? And also in the surgery report, nothing about a dislocated anchor was mentioned. Okay, good. Then, yeah. So what we wanted to do is have a look at the scar tissue again. Probably very good visualized on this kind of sagittal orientation. We see the rectus femoris tendon going to the anterior inferior iliac spine here. This is the pars recta, direct head because it's very direct, it's straight, right? Pars reflexa makes this kind of movement backwards and is slightly bended and reflected, if you will, hence the name. And first of all, there's not a lot of substance left. It looks strange. Normally there's more tendon. And if we check the axial here, we can see the rectus femoris tendon going up. We see there is some fluid undermining this. So there's not a lot of stuff going on. And then we've got this kind of, here some of it might be joint capsule. If we go down, you can see some of it is iliofemoral ligament. Then we've got some scar tissue here, some adhesions. So I think all of this is a lot of scarring going on, and also joint capsule might be thicker than it normally is. In this gap, there are also these small adhesions, all this tiny stuff there, covered by the membrane that they already saw in the arthroscopy report. So remember, the surgery, the arthroscopy report that I'm showing was done after this MR. So basically what they see is what we should see or should be able to see here. Okay, now going back to the translation. So no continuous defect. So sometimes they see sutures, but these are just the threads. It's not metallic. They just sometimes remove them, sometimes they keep them. So 1 to 3 centimeter capsular defect. So this is clearly, if I just put this away, this is clearly this defect, 1 centimeter and in about 3 centimeter in craniocaudal dimension. So that's perfectly consistent with this finding. So it is likely that the sutures here tore out early post-operatively. Make kind of sense because they wouldn't leave the joint with this kind of gap. So what they do, they go in, they go out, and then they fix the joint capsule together. And so they are suspecting an early post-operative tear of the sutures. So in the peripheral recess, two large sail-shaped, so this kind of sail-shaped scarring between capsule and femoral neck are visible. They are removed again. So again with the other patient, the first patient, it's similar. They saw some adhesions there. Peripheral recess, so what they mean is probably the peripheral recess. I think it's this area here. Sometimes we struggle with the resolution. Let's see whether we have some kind of radial imaging. So this is very bumpy oriented. Yeah, this one's better. Oh, again, same problem. This is, there is still a lot to improve. All right, so yeah. So this is now the anchors, and this is superiorly, more or less, laterally. Okay. So if you want to know on radial imaging where anterior and where posterior is, just look at the gluteus maximus. It's easily identifiable here. So you know this is posterior, this is anterior. So this is one way to do it. So what we are now trying to find are these two small sail-shaped adhesions in the lateral recess of the joint. I don't know, maybe this one or this one. It's hard to say. So still gluteus maximus, and this is now more laterally. Here are some very subtle changes. This one, probably one of these, was one of the adhesions that he mentioned. Go bigger. This one, and not really sure whether we can see any more than this. So, but again, I think the extent of these kind of adhesions are not sufficient to be really symptomatic, and as I already said, 1/3 of patients has any kind of adhesion there. So the more relevant adhesions are these kind of changes along the along this area, along the pars reflexa, I guess. Okay, now let's put this away and go back to the report. Okay, so yeah, offset fully corrected, that's okay. The femoral neck is covered with a scarred membrane which appears patchy and looks like newly formed cartilage islands. So this is probably something we cannot really appreciate. It's now quite unfortunate that I don't have the pre-operative scan, but to try to identify patchy cartilage islands that started to form here, it's probably not possible. This one probably also, maybe they even mentioned or thought that this would be sail-like adhesions, potentially. And they seem to be connected there. So maybe I should use not a 3D, but maybe a very thin slice. Although so it's not really better visible. So there is an adhesion, as you can appreciate it. This one, and maybe some down here. I think that's what they actually meant. And the femoral neck covered by a thin membrane with patchy island of cartilage new formation, it's not something we can or should see, okay? I don't think we should try to see it. Going back to the report here, the cartilage cover, that's okay. Is frayed at the edges, but shows superficial alteration to the acetabular margin. The capsulolabral recess is virtually completely scarred. That's what we expect, right? Best seen on these kind of images here. So there is, not in the more posterior portions, but here, up here, everything is completely scarred, and that's what they actually meant with this. It's also this very frequent finding. Oh, again, I'm sorry, this is so stupid. Okay, I should probably share a screen rather than windows. So again, completely scarred, that's what we expect, right? All this stuff. This one, okay. Okie dokie. Now going back to this report that's coming in my way all the time. Oops. Yep, there it is. So no vacuum effect. They go into the joint. Superficial erosion and alterations on the acetabulum, especially anterolaterally. The controllable junction is scarred, but show no new crack formation, no delamination. Okay, so there are some changes on the anterolateral portion of the acetabulum. This is really hard to see, to be honest. Let's see what kind of sequences we have. Sometimes best seen on the sagittals. So there is probably something going on here where the patient had prior damage at a very typical location, and this is where we would expect this kind of acetabular cartilage changes or erosions. Superior region of the acetabulum, obviously at the area where they had to fix or correct the labrum, right? So this is where the stuff happens anyway, so it's probably best to just have a look there. Nothing major on the femoral side. Some of it is susceptibility artifact. I don't think it's real here. And yeah, so this is not easy to really follow. And the trophy here is not really helpful because of the susceptibility artifacts and also because of the orientation. Can maybe look this way. It's the same area where it looks just a little bit irregular, right? Radial imaging obviously can be a good help. It's this one here, not this one, this one. Zoom in. So, okay. Yes. So it's not normal signal. Some alterations might be possible there. It's very subtle. It's not like no major defect. Certainly we don't see any fluid undermining the cartilage, no delamination, also no like very obvious black line that would indicate a closed delamination of the acetabular cartilage. So I think we can agree with this finding. Now going back to the report here, and we can see fovea centralis shows small free cartilage particles, otherwise there are no abnormalities. Ligamentum teres intact. Okay, ligamentum teres, I think it's always worth looking at the ligamentum capitis femoris or ligamentum teres, however you want to name it, because it can be a pain generator of the hip. So here we have it, fovea. We've got the normal ligament here. It has normal intensity of the signal. It's not thickened. It's not mucoid degenerated. It's no fraying. There is no fraying, etc. So it's completely intact. I've seen cases with unknown hip pain after trauma where they had a complete rupture of the ligament and some bone marrow edema in the posterior aspect, and actually it can be an indication of a occult hip dislocation or subluxation with spontaneous reposition. So always have a careful look at the ligamentum here. Now they mentioned some cartilage islands in this area or cartilage fragments, so I don't think this is something we can see, and if I remember correctly, the arthroscopy image, it must have been less than 1 millimeter, 3 or 4 patchy cartilage fragments there. Nothing we can see on MR and not worth trying to see, right? Okay, I'm going back to the report here. Yeah, femoral head, grade 1, diffuse chondromalacia. This is also very not really fantastic. We can see there's very subtle irregularities, which is kind of expected if the patient has these kind of changes on the acetabular side. Stupid. I'm sorry about this report popping in all the time. I have to find a different solution for this. Yeah, on the femoral side, there is some very subtle irregularities that I'm not sure whether I would call them prospectively. Certainly, what I sometimes like to do is I just say there is no deep defect. If you just say there is no deep defect, it doesn't exclude superficial defects, and you just don't comment on it. Right, that's one way to do it. And I think that's basically all for this report here. So they removed, and then they just write what they actually did. So nothing too major. Okay. Oh yeah, and so this is the DeepL translator, very good tool in case you're interested. So before we move on, can you please write in chat where you're actually from, because it's very interesting to see. So there is one guy from Guatemala, Uzbekistan, based on the name, someone from Russia, Germany. So yeah, and hi to everybody. Oh Bruno, oh dear, 11 euros. So thank you so much for donating this. It's great. It's not the idea to do. Also Berlin case here with 3 euros. So thank you very much, guys. It really means a lot. It's quite funny to do this. Actually, I like it a lot. It's not very formal. I learned something myself, and you guys obviously seem to like it. That's great. Yeah. So always happy for feedback. Italy, Lithuania, Belgium, Poland. So that's great. Italy is twice. That's great. Oh, you guys have late already. It's 10 o'clock. So I will not keep you on much longer. I think I've got one more case number 3. And we can quickly go through that one, because this one is not a post-operative. This is not a post-operative MRI. It's just a pre-operative MRI, but I just copied the let's say the surgical note out of it. So what they did actually in arthroscopy was smoothing of the controllable transition, some acetabular microfracturing and offset correction. And this is the story of the patient, a sport young patient, left groin pain, no osteoarthritis, and MRI showed controllable damage and clear offset disorder. So they had the indication to go in. And so they went in, they went through the joint capsule. Capsule is clearly visualized. Then they split it along the iliofemoral ligament. They have now a good overview of the peripheral compartment. So remember, you can see this even with the report. So the peripheral compartment is basically not the central or internal compartment, but more on the lateral side of things. And the expected offset disturbance was confirmed with a deep ulceration extending over the entire ventral head-neck junction. So they saw an ulceration on the ventral entire head-neck junction. So I think I want to see this. Let's see. So it's a little bit a different protocol, as you can see here. Let's see. So first of all, we can obviously see the head and the cam deformity, and there is a radial image here. And we can understand the offset is flattened. We've got this kind of bump here. Okay, so it's not the best radial image, so we can quickly see whether we can do this better. So you can do this on any 3D sequences yourself, basically just like this, and then have it in the femoral neck here like this. So you can basically just rotate yourself and get a good idea where you have actually the largest extent of the cam deformity. And I think it's this here with this bump. So the ulceration is on the anterior portion, so probably somewhere in this region. So with ulceration at this level, we don't necessarily expect a lot of cartilage anymore. So what would the ulceration be then? Periostal, for example. But anyways, we can't really appreciate this on the MR. The cartilage here of the femoral head here, and then at the level of the head-neck junction where it gets thinner and thinner, is quite okay. We don't see bone marrow edema, we don't see any herniation pit at the level of the cam deformity. So this is probably something that we are not able to see here. Maybe there is some irregularity here, but this is now just on one slice, and we obviously have problems seeing this on the other slices or other orientations. It might be just some partial volume. So let's go back to the report. Can't really see it. Webcam, no. Oh, this one, yes. Alrighty, so expected. So Lateral to this is a bony bump. So the ulceration is medial. If I put this a little bit to the side, the ulceration is medial to the bump. So that would be in this area here where we cannot really see something, right? So lateral to the bump. The bump is lateral to the ulceration, so we don't see it. That's it. No osteophytic reactions. Okay, the spherical head region shows only superficial erosions and chondromalacia grade 1. So the spherical head has some chondromalacia. Let's see. So this sequence is no use. This one also not very good contrast. Not really sure what these two dots mean. There might be some very superficial irregularities, but again, nothing really jumping into our eye. And I think sometimes this kind of chondromalacia grade 1 findings, it's just not possible for us to really make these calls. And also not really super important either, I guess. So I think prospectively I wouldn't call this. Again, what I would probably say is just there are no deep cartilage defects. And remember, oh, I said it wrongly. So this patient is clearly over 50 years old. So just to keep that in mind. So we would expect some kind of cartilage degeneration at this time anyways. So I would probably just say, okay, there is no like deep cartilage defects on the femoral side of things, no subchondral bone marrow edema, and not really comment or trying to comment on very tiny superficial changes or just degeneration of the cartilage. It looks not too bad. Okay, he's got some stuff going on there as well. Anyways, going back to the report here, what else did they see? The labrum lies well, good tension. When extension is applied, it shows good vacuum effect. So they pull on the leg and the labrum keeps the head in place. It is this kind of vacuum effect. So basically it has still preserved its function. Then they just pull the head out, go in with the scope into the central compartment, and then they see a 2 centimeter long chondrolabral fissure. So we should certainly be able to see a 2 centimeter long chondrolabral fissure, which extends to the bone. Incipient delamination of acetabular cartilage layer up to a maximum of 5 millimeter width or wide. Okay. So this is something we now want to see. Look this away. Okay. So let's see. It's a bit of a strange protocol. Anyways, let's try. And we know, just based from experience and statistics, that these kind of lesions will probably occur in the anterior superior region. And this is now laterally, and we can start to see here at the base of the labrum some hyperintense signal changes. Yeah, you can see this. There is even signal change into the labrum substance. Here, it's too bright, so, and here, this one here. So this kind of fluid also undermines a little bit the cartilage, and this is consistent with a chondrolabral damage and or separation as well as they described in the surgical report here. So this is certainly what they saw. And we can now try to find out the exact length of this finding. Let's see, how do we do this? We need this one and not this one, maybe this one. Okay. So where do we see it first? So, okay. We see it here first, so at this area, and I think we can already appreciate it here, this kind of fissure, this one, and probably lasts up to here. It's hard to say. Let's see, we can see it here, we can see it here. Let's go bigger. Here still there is the chondrolabral junction is damaged, this one as well, so it goes up to here, so certainly from here to here. If we measure this, well, 18 millimeters is not too bad, and if we think that it's actually a curvature, so we should fairly fall in this 2 centimeter region. So this is quite consistent with what we see here on this MR. And I think it's very good to not just look at this one image and then describe the lesion, but really try to find out from where to where it's going. There is no sagittal plane acquired, which is kind of strange. And I really like that we can see it also here on this plane. Maybe the radial imaging is a little bit better. Let's see. So again, if you don't know where your gluteus maximus is, this large stuff, and then you know you're posteriorly. There. So this is the same image basically, but I don't like this sequence either. It's not just a strange contrast between cartilage and fluid, so not really good. But it goes from here, 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 then some delamination there going on as well. So now let's jump back to the report. I think we are about to finish. Slightly frayed. It's just this kind of fissure. It's not that there is like extensive cartilage damage. It's just basically a fissure that's going through, and that's what we nicely saw or can see. And I put this next to the report here. This one, it's this fissure here. Okay, it's very good. I like that. All right. Then what else? Outside of the actual impingement, diffuse superficial cartilage damage on the acetabular side, grade 2. Outside of the actual, okay, so outside of the actual impingement zone. Let's try to see this. Boom, boom, boom. Where do we look for this? Maybe here. We've got some signal changes here. The signal is here slightly brighter than there, so it's probably just overall not very good quality cartilage anymore on the acetabular side, more so than on the, so femoral is it's not too shabby, I guess, but it's not like there is fluid going in or there are large chunks of cartilage missing. Very interesting. Okay. Yeah, good question. Do you really believe everything they write in surgical reports? No, not always. So I've seen shoulder arthroscopy reports where they reported the subscapularis, not the infraspinatus tendon as completely normal, but it was completely torn, and there was just some capsule or I don't know, some kind of lining covering the humeral head there, which must have looked intact from inside the joint, but on MR it was so obvious that it was a complete tear and completely retracted tendon. So, but we can't really argue, and I unfortunately don't really understand the arthroscopy images. I can't really orientate there. So let's see. Smaller free cartilage particles around the fovea. Teres intact, removed, microfracturing applied. So what they actually did to stimulate scarring, microfracturing is applied into the chondrolabral fissure, specifically under the detached cartilage particles. And yeah, I think that the rest is basically not really important anymore. So I think that's it. I think I will conclude this now. In case you have any questions, feel free to ask. I think we can still do 5 more minutes and then we should all go to bed. Yeah. So thank you so much for joining me today. This was the first time now. I think I'll be doing this maybe once or twice a month. We'll see. And yeah, it was good. So there are some glitches that I still need to figure out. Something I certainly will be able to do. And if you have any recommendations what I should change, especially if sound was loud enough, or I don't know, image quality, resolution wise, I'm more than happy if you let me know. Make sure you subscribe to my channel, but I guess most of you are anyways. And if you like what I do, consider to become a patron. You can check my Patreon page. You find the link in any video on YouTube of me, so there is enough links. Then you can see what you actually get as a benefit. It's not just that you would supply basically the course, but also you get exclusive videos in back as a return. So we'll see the chat here. So thank you, amazing. Okay, that's great. Yeah, can you save the live also? Yeah, so just to remember that this live session, so if you stream on YouTube, the video automatically goes into the library and you have access to the video anyways all the time, unless I would decide to hide it behind some kind of a yeah, I can just put it away if I want to, but I won't. So I leave this in the open for everybody to see that did not have time to join us today. Yeah, anything else? Yeah, Norway. Hi Norway, that's great. Yeah, which app you use to analyze these pictures? So this is just a PACS viewer. It's called Merlin by Phoenix Systems. It's a German company. It's easily the best PACS viewer out there. I still have to see a better one, so it's a good one, really. Yeah, Berlin case viewer online as well. So one question I would have to you guys: do you think if you would be able to scroll through the cases in parallel with me, whether this would actually be helpful to you? So for example, on your phone, you would have the same cases that I just showed you. You could scroll through parallel with me. If that's something you would be interested in, just let me know in the comments, because we could certainly try to do that together with the Berlin Case Viewer app that I used in my last or second last video. That's a tool that we could certainly use also for this kind of streams, if that's something you would be interested in, or whether you just want to keep your eyes on the video and follow my mouse. Yes. All right, so I think there's not much left to say. Feel free to share the link of this video. It's available right away on YouTube. Feel free to share it on your social media platforms. And with that, I wish you all a happy weekend. Stay safe. Enjoy lockdown. I saw one guy is from the UK as well, so Ben. So I'm in the UK as well, so lockdown kind of sucks, but it's a good time to do some streams on a Friday evening, isn't it? That's one of the upsides. All right, so what else? Nice video. Which approach do you prefer for hip arthrography? So which approach I use for hip arthrography? It's very easy. I always do the following approach. So AP a little bit externally rotated, or basically a little bit elevated hip, so that the nerve etc. goes this way. If you elevate the lateral portion, it goes a little bit more in this direction, the nerve etc. So you are less likely to puncture any relevant structures. And then I point the needle just down to the neck. That's my target site. Unless, there are two caveats. If the patient had prior hip surgery, I put the needle here. And the reason is because if the patient has adhesions in a post-operative setting, you can, or even if the joint capsule is very thick, etc., you will have a hard time injecting contrast at this level in the arthrogram. And here it's very easy to do. You can always use this approach. It's never wrong. In my experience, it might be a little bit more painful, and I think the reason is because depending on how the coverage is, you might, or you're very close to the labrum, so potentially you occasionally hit the labrum. This one I think is causing less discomfort to the patient. And this is also a very good approach if you have very thick patients. For example, if you have a very adipose patient, and if you think where you put your needles in, if you go to the neck, you need the longer needle than when you go to the head. That's just one thing. And sometimes 12 centimeter or even 17 centimeter needles, spinal needles are not enough to reach the joint here, so you can then go to this approach. That's one question. What else? For more details, yeah. So I understand. I went through the cases quite quickly, because I wanted to go through at least 3 cases anyways. If it's too fast, maybe if the other guys can also point this out. If it was too fast, then just let me know. But I specifically do not want to give an introductory lecture to, for example, hip MR anatomy or stuff like that. So I'd rather have you guys to be already a little bit in a more advanced stadium, and then we take it from there instead of going through every basic finding. But it's good. I mean, if that's a common feedback, I might certainly change this. Can we submit our MRI for your interpretation? Yeah, you technically can. So I have a company and we actually offer second opinions, but obviously not for free. So that was the question by Damien. If you want to know more about this, just contact me, and if you are interested in any, I don't know what you mean with submit our MRI for your interpretation. Is it just your, or do you want to send all your institutions MRI for interpretation? Then also contact me. We can always talk. It's never wrong to talk. Yeah, so the written report would be helpful as well. Diogo mentioned this. That's something I could certainly do. I could put the text in the description of this video. Let me just join in here. Yes, I probably would be able to share a link or so. That's fine. Can certainly do this. That's a good point. Thank you, Diogo. Okay, do you determine the alpha angle? I never measure the alpha angle, to be honest. Not on radiographs, not on MR. I think it's kind of pointless. Just basically because the overlap between, so if you remember the curve from asymptomatic and the curve of the values from symptomatic patients, there is so much overlap between the two curves that it renders the measurements basically useless. Maybe not completely useless, but if orthopedic surgeons want to know this value, they can measure it themselves. Also, there is so much inter-reader variability, so I don't care. Yeah, okay. Yeah, so I think the 1 hour is up now. That's it for today. Thanks for watching, and see you next week, hopefully, right? Yeah, okay. Bye, guys. Where do I start?